What we're going to do now is get on to the final presentation for this work stream, and indeed for HACA 2025 before the closing remarks. And you're very lucky that it's Tom Prendergast, from a senior data analyst at the Health Foundation, who's going to talk about the Networked Data Lab. What can linked data tell us about the elective care waiting list? So over to you, Tom.
Hi, everybody. Thanks so much for the intro. As David mentioned, my name is Tom Prendergast. I work at the Health Foundation, and I'm a senior data analyst on the Networked Data Lab team. And I'm here to talk to you today about our work that we've done over the past year or so on the elective waiting list using linked data in several different localities in Britain. Within the foundation, I work on the Network Data Lab, or the NDL. So the NDL is a network of analytical teams that are funded by the foundation, and we work together using linked data to analyze key shared issues in health and care. So the 5 labs that we work with are in Northwest London, Leeds, so West Yorkshire ICB, Cheshire and Merseyside, Grampian, and in Wales, covering the whole country of Wales. And all of these locations were selected for participation in the program because they already had particularly advanced and extensive local ecosystems of linked health and care data when the program began a few years ago. So we collectively choose a different topic to focus on every year. And for 2024-25, that topic was the elective care waiting list. So to start with the initial scoping phase for that work, so we spoke with stakeholders to form our initial research priorities, which included several different teams from NHSE, including the elective analysis team and the National Healthcare Inequalities Programme. We also spoke to GIRFT, Getting Right First Time, as long as other leading health and care analysts from the Strategy Unit, the King's Funds, Nuffield Trust, and others. And we also had input from the local elective care teams in all the NDL labs, various ICBs, so hearing what their local priorities were and what would be most helpful for them on the ground. And we also discussed the potential research questions with a panel of patients and the public who we continue to engage throughout the whole project lifecycle, so right from the formation of the research questions up until the final publication that we produced based on the work. So the purpose of all this engagement was to identify where there are gaps that decision makers or patients in the public would like to see filled, and in particular where there's knowledge gaps that the NDL, with its access to these very extensive linked data systems, would be well poised to fill. And so from those conversations, we found that there was 2 primary topics of interest that came up again and again. So we heard that there were, this was about a year and a half ago that we were doing this, and at the time we heard that there were research gaps surrounding measuring the impact of waiting for elective care on patients and on the health and care system. So this is, of course, something that requires linking data on the waiting list and waiting times to wider health data, so to primary care, to secondary care, prescribing data, etc. And not a huge amount of research had been able to do that before. And the second question was about understanding who is disproportionately impacted by waiting. So that's both disparities in waiting times, but also in terms of impact on health. So there wasn't much information out there on disparities in wait times yet when we were scoping this project. Of course, more recently, data has been released by NHSE, which covers disparities in waiting times between population groups. And in terms of impact on health, of course, that would require the same linkages as the first question would. So these were both identified as gaps that the NDL would be well suited to fill. And so based on that, we put together 3 core research questions, and they were explored for all patients who were waiting for elective care, regardless of what procedure they were waiting for. So this covered all specialties. So first we examined how long people were waiting, as well as the reasons that people were removed from waiting lists, so why waiting periods ended. And we also looked at how much healthcare people used before, during, and after being on the waiting list. That question was only examined for people whose waiting times had ended with treatment. And for each one of these questions, we examined how all of these metrics varied by demographic and health characteristics. Just as a note, the standards that we measured waiting times by are slightly different between England and Scotland. So in England, we use the RTT standard, so from initial referral to first treatment or any other reason for a clock stop. And in Scotland, we use the treatment time guarantee standard, which is for inpatient waits only, and is measured as time from agreement for inpatient or day case treatment up until the receipt of that treatment. So important to keep in mind when we're comparing stats from our English labs compared to those from our colleagues in Grampian, that what they're looking at is slightly different in terms of the population who it's looking at and also the periods of time that we're examining. So the range of data used by each lab to answer those questions varied, but there were commonalities between them. So, for instance, in English labs, extracts from SUS were used for secondary care contacts, including emergency care, elective admissions, and outpatient attendances and emergency admissions. All of them also had access to data on GP appointments and other primary care events, which our colleagues in Grampian didn't have access to. And in all English labs, the waiting list minimum data set, or the WLMDS, was used to provide information on waiting periods and waiting times. In Grampian, the Scottish morbidity records, general acute inpatient and day case data set was used for those purposes. And if anybody else is interested in kind of how we process the WLMDS and how we used it for this work, because there's some kind of quite idiosyncratic challenges to that. We actually wrote a blog on that topic, which we'll link via a QR code later on in this session. So just to start with the results for our first research questions, this is on how long people were waiting for and how this differed across population groups. So we found that although most waiters were waiting for 18 weeks or less, still 27 to 33% of people were waiting for longer than that, depending on location. So this is quite a bit off of the NHS target of 92% of people coming off the waiting list within 18 weeks. And then when we broke that down, we found that waiting times differ dramatically by specialty, which we'll go into in more detail in a moment. But along with that, somewhat unsurprisingly, older people, people with higher frailty and more long-term conditions tended to have shorter waiting times. This probably, isn't something that we would think about as an inequality, but it rather reflects local prioritization decisions based on need. People who were waiting for more than one procedure also tended to have longer wait times than people who were waiting for only a single procedure. And otherwise, there did appear to be inequalities in waiting times between ethnic groups and quintiles of deprivation. So, for example, we saw that patients who lived in more deprived areas in almost all cases had longer median wait times than people who lived in more affluent areas, and also that people with Black, Asian, or mixed backgrounds tended to have higher average wait times than white patients did. So as I mentioned, specialty was the stratifier that we saw the widest range of variation around in terms of wait time, both between categories, but also between NDL locations. So as we can see here, while there are some specialties that have uniformly long waits between locations, so for instance, trauma and orthopedics, where almost all labs had more or less the exact same median wait time. In many cases, there's quite a wide range of median wait times between the various NDL labs within each specialty. So for instance, you can see here that neurology and neurosurgery had particularly long wait times in Northwest London, while gynecology was particularly high in West Yorkshire and Cheshire and Merseyside, but less so in Northwest London. So here we can see breakdowns of inequalities in wait time by ethnic group and deprivation. The differences aren't necessarily huge, but they are present. And the patterns that we observed here are roughly in line with the national patterns that you can observe in the data that NHS England have released in the past couple of months. And then when we cross-tabulated that with other variables, we saw that inequalities by ethnic group appear to remain even when accounting for differences in IMD distribution. So, for instance, you can see here that within the most deprived quintile, those differences in median wait times, this is median wait time in days, still persisted. So within categories, not just kind of across all categories. And they also often persisted when accounting for age as well. So we can see here in terms of IMD that when you break it down by age bands, this is an example from West Yorkshire. Once again, these inequalities between the least deprived and the most deprived areas persist within age bands. And then we also performed this exercise where we created kind of expected mean wait times in terms of kind of taking the local age distribution of different ethnic groups in NDL areas and then kind of modeling what we would expect their wait time to be based on that. And we found that in almost all cases, the observed difference between ethnic groups was greater in the actual observed data than it was among the expected wait times that were modeled. Then to look at our second research question, so regarding why people were removed from the waiting list. So this was a question that we had trouble answering fully because of poor data quality. So North West London and Leeds, around 40% of reasons for leaving the waiting list were unidentifiable in the data. And this variable has this problem for a couple of reasons. So on the one hand, in some locations, it's just poorly or inconsistently filled out because of either validation issues or technological limitations. So the WLMDS, the waiting list minimum data set, is submitted on a weekly basis, not on a monthly basis like the RTT data. So its validation thresholds are lower and it's not subject to kind of the same level of validation before it's released. But also in some cases, data will have stopped being submitted for a waiting period for some time, even though no clock stop was submitted. So there's not a piece of data specifically saying this pathway ended, but data hasn't been submitted on it for a very long time. So it's assumed that those pathways have ended, but we obviously don't know why they ended because of that lack of data. But data was sufficiently filled out in Cheshire and Merseyside, where only about 5% of waiting times had ends that we couldn't identify. And in Cheshire and Merseyside, we found that less than half of pathways, so about 48%, ended due to receipt of first treatment, and nearly a third ended due to decision not to treat. Which is a category that encompasses quite a wide range of pathway ends, which we'll expand on in a moment. But very few pathways ended due to did not attends. It's less than 1%. But the rate of did not attends for the most deprived quintile was double that of the least deprived. And reasons for leaving the waiting list, much like wait times, varied most markedly by specialty. So we can see that specialty level difference here. So there's some not especially surprising results, like for instance that plastic surgery had the highest rate of clock stops due to first treatment, while elderly medicine very frequently sees pathways end due to the initiation of active monitoring. But there are some curious ones. So some very long waiting specialties, including neurology, gynecology, and ENT, all have relatively high proportions of pathways that end due to decisions not to treat. So this raises questions about whether the long wait either caused the condition to change in some way that perhaps it needed the approach needed to change. But also this could signal people dropping off the waiting list because someone dropping off to pursue private options isn't separately identified as a reason for waiting time ending. That actually falls into the decision not to treat category. So we don't know exactly how many people might be responding to long waits with that option, or if these decisions not to treat are happening for other reasons. And obviously, we are also limited by our lack of comparators here. But one of our key takeaways was that this is a variable in the data that should be given special attention in future data quality improvements, because there's some really crucial information that isn't that clear in the data currently. Then our final main research question related to how much healthcare people used before, during, and after their waiting period. So what we found here was that aside from GP appointments and prescriptions, healthcare use was relatively rare across the cohort. So even after cost weighting, GP appointments in all cases substantially outweighed A&E attendances, despite an A&E attendance, of course, being much more expensive form of contact with the healthcare system than seeing a GP. And we also saw that deprivation was associated with higher healthcare use across all time periods, but especially while waiting and particularly in emergency care categories. And then finally, something that we noticed that was quite unexpected was that people tended to use more healthcare before and after being on the waiting list than they did during the waiting period itself. So we would assume that this reflects increased healthcare use, possibly while trying to receive a referral in the period before they officially joined the waiting list. And afterwards, this could be care for complications or follow-ups in the immediate aftermath of treatment. These are patterns that did vary somewhat by points of delivery, though, and they weren't always consistent between specialties or between population groups. So there's a number of specialties which saw the highest rates of healthcare use during the waiting period, especially those that are aimed towards older patients, such as elderly medicine. And that might indicate some additional challenges for people waiting for particular services or who fall into particular population groups compared to others. So just to zoom in a little bit more on some of those results. So we can see here some of these patterns in healthcare usage, as this is an example from West Yorkshire. And this shows GP and A&E attendances weighted by the average tariff associated with them. And that's per 100 person weeks. So this is adjusted for waiting time. And both A&E attendances and GP appointments are higher in the 3 months before the waiting period, lowest while waiting, and then rebound after, although not quite to the height of the pre-waiting period. This was relatively consistent across all NDL locations when looking at all specialties and patient groups together. So this is generally true in the aggregate, although when you break down by specialty or by group, sometimes these patterns do change. And then we can also see here that after cost waiting, as I mentioned before, GP appointments far outweigh A&E attendances, despite the fact that on average an A&E tariff is about 5 to 10 times the cost of a GP appointment. So of course, if this wasn't cost weighted, the amount of GP appointments kind of in raw events would be far, far larger than A&E attendances and would outweigh it even more than it does here. And then when we look in a little bit more detail at the post-treatment period and we break it down by wait length, we can see that longer waiters actually had relatively greater increases in healthcare use after treatments than people who waited below 18 weeks. So in this example from Northwest London, we can see emergency care, so this is A&E attendances, go down compared to the waiting period for people who waited below 18 weeks. But it actually increased for people who waited more than 18 weeks, with the relative increase going up as wait lengths go up. We should mention here that this is relative. This isn't in absolute terms. So the shorter waiting groups, which tend to be older, they tend to have higher frailty, more long-term conditions, etc., than longer waiting groups. They do almost always use a lot more healthcare than those longer waiting groups do in absolute terms. But what we're looking at here is relative differences in their healthcare use while they're on the waiting list compared to after they leave the waiting list. And then finally, in terms of variation between population groups, so we can see here that there's quite a clear gradient in between the most deprived quintile deprivation compared to the least deprived. This is in emergency care. And this is something that we did observe in most points of healthcare delivery and in all time periods that we examined as well. But the relative difference was greatest within emergency care, for one thing, which I think is expected and kind of in line with most other literature. But also the difference was greatest during the waiting period. So this does imply that perhaps even though the general patterns we saw implied kind of less healthcare use during the waiting period compared to others, this does maybe imply that some population groups face quite particular challenges during the waiting period compared to others. So in terms of next steps, we have 2 pieces of follow-up work planned on the elective waiting list. So on the one hand, we're currently working on a more detailed analysis of NHSE's recent releases on elective waiting time inequalities, and also on a project investigating the factors associated with greater emergency care use following the receipt of elective treatment. So that's kind of looking at that result that I showed before, showing how the relative increase in emergency care use went up as wait length went up. Obviously, that's just kind of like quite a simplistic descriptive finding, but we're kind of planning a more elaborate causal analysis that would actually aim to isolate the effect of wait time and try to investigate whether it is wait time that appears to be increasing those groups' healthcare use after treatment. I think there is actually supposed to be one other point here, which is just on impact, which is that recently we heard from our colleagues in Grampian that deprivation has been added to the kind of roster of information that clinicians are supplied with in making prioritization decisions based on their work on the kind of relationship between deprivation and increased healthcare use and increased challenges while on the waiting list. So in terms of the future of the NDL, so as a whole, we've moved on to our next topic, which is on housing and health. And at the end of 2026, the NDL program will end altogether, but we will be putting together one final piece of work, compiling learnings from all our previous projects. So the NDL is a very large network, and there's many, many people to thank. So we have authorship and acknowledgements here. And then we also have QR codes for the various publications that we produced based on this work. So we have a briefing which summarizes all the results that I've just gone through and more. We have a blog that was published in the HSJ, which goes through some of the policy implications of our results. And then finally, we have a blog about working with the waiting list minimum data set, which is on Medium. But yeah, that's all for me. Thanks so much.
Thank you, Tom. Another brilliant presentation. Apologies to you because I'm sure there's lots of people, lots of questions for you, but we're going to need to just move to the final session now. Really great presentation, though, Tom. Thank you. And again, do reach out to Tom using the people function. So all it leaves for me to do is to thank you very much for joining this stream today. And I'm not going to hold you up any longer than that because I'm sure you want to get over to the closing session where Andy Orlowski is going to provide some closing remarks for HACA 2025. So thank you again, and they're waiting for you over in the main room. So go and enjoy that final talk. Thank you so much.